Hello guys. Yes, 5 marks very important questions and answers of a Pharmacology-2. After a hard working days, I am here with a very important 20 questions in Pharmacology-2. Okay, those asked repeatedly in your previous year question papers. So if you familiar with these questions and respective answers means these are enough for your examination. Means in spite of in the session of 5 marks. Already we had uploaded the 10 marks questions and also 5 marks questions with answers. Okay, today inshallah we will complete the chapter of the pharmacology 2. Next let's discuss about the industrial pharmacy 1. Yes, now the important questions, first only I will discuss the direct questions. After the discussing of the questions, the particular question with answer we will discuss in the next slide. Okay, so watch the video until last. Be patient here. Yes, the first question is the pharmacology of the statins. You have to write here what the pharmacology of the statins. Then pharmacology of calcium channel blockers. Don't worry, you will get each and every information about the particular question and how to write, what to write in this video. Now the third question is oral hypoglycemic agents, asked many times in our examination, and pharmacology of hydrocortisone. Okay, see here some synonym also there here, means the word which is preferred with the other name. Okay, now see if they ask glucocorticoids, you know that glucocorticoids, it is a steroid which is released from the human body, natural steroid. If they ask glucocorticoid means you write the same pharmacology of hydrocortisone. See, these some tricks are there you will get in this video. Then pharmacology of prednisone or prednisolone, this is also one steroid. Then pharmacology of loop diuretics, clear. Then propyl thiouracil. Then pharmacology of a furosemide, heparin, clear, heparin. Then pharmacology of the prostaglandin, classify antihistamines. Then pharmacology of glibenclamide. If they ask glibenclamide, you write the same pharmacology for the sulfonylurea also. Sulfonyl type of compounds. Later we will discuss in that video. I am not sure here that is sulfonyl or what, but you will get in this video. But you remember pharmacology of glibenclamide. Glibenclamide, it is one of the oral hyperglycemic agent. Oral. If hypoglycemic agent, to treat the high sugar level we are giving this glibenclamide. Yes, next is a hypoglycemic agent, that is glibenclamide. Pharmacology of captopril, this is also asked many times. Then pharmacology of the carbimazole. Then pharmacology of diclofenac, pharmacology of insulin, pharmacology of nitroglycerin, pharmacology of the warfarin, pharmacology of the oral contraceptives. Clear, these are the important questions, 20 important questions. Now the first is a pharmacology of the statins. Let's discuss. Yes, now what does this statin says? Pharmacology of statin, which our first question, what is statin? First you write what is this statin. See, statins are a class of drugs used to lower cholesterol levels by inhibiting the enzyme HMG coenzyme A reductase, which plays a central role in the production of cholesterol in the liver, which produces about 70% of the total cholesterol in the body. So here these statins, actually what these are inhibitors. Okay, these are HMG coenzyme A inhibitors. What they will do means they will decrease the cholesterol levels. Okay, they will decrease the cholesterol levels. How? By inhibiting the enzyme HMG coenzyme A. HMG coenzyme A, it is one enzyme which helps to maintain the cholesterol level, or which produces the cholesterol, which synthesize the cholesterol. Okay, these synthesis of the cholesterol is inhibited by the HMG coenzyme A reductase inhibitors. Okay, that this role means HMG coenzyme reductase inhibitors role is played by these statins. Okay, in your home you are referred that means you are familiar with that, your grandpa or grandma, they are suffering from cholesterol level, high cholesterol level. Why? Because of hypercholesteremia, or because of the HMG coenzyme A, which stimulate to the synthesis of the cholesterol. Okay, that stimulation is inhibited by these statins. Simple, this one. And 70% of the total cholesterol in the body is produced by the liver. Clear? This you have to understand the topic. Yes, now the next one is a mechanism. What is the actual mechanism of these statins? How they will work? See here, how they will work means by inhibiting HMG coenzyme reductase, statins block the pathway of synthesizing cholesterol in the liver. Directly, they will attack on the liver and they stop the cholesterol synthesis. This is the simple mechanism of action. Then this is a significant because most circulating cholesterol comes from the internal manufacture rather than the diet. Okay, most cholesterols like your triglycerides, okay, these all comes from the internal skeletal muscles or anything, like for an example you take bones, in bones skeletal muscles, from that also, or from the liver, these cholesterol will get synthesized, not from the diet very less. Okay, when the liver can no longer produce cholesterol, next point, levels of cholesterol in the body will fall. Yes, obviously if the liver won't produce the cholesterol, means cholesterol level decreases. Cholesterol synthesis appears to occur mostly at nights, so statins with short half lives are usually taken at night to maximize their effect. Actually we are taking these statins to lower the cholesterol level at night only, because they will means cholesterol synthesizes night only, so directly they will go and stop the synthesis of the cholesterol by acting towards the liver. Clear? Next is studies have shown greater LDL and total cholesterol reduction in the short activating simvastatin taken at night. Simvastatin, it is one of the statin. You are observing the last suffix here, statin. These are the statins, simvastatin. They are taken at night rather than morning, but have shown difference in the long acting atorvastatin. Simple, remember this one. These will, what they will do, they will just go and inhibit the synthesis of the cholesterol in the liver. That's why the cholesterol synthesis decreases, so the cholesterol level also decreases in the body. Okay, this is the role of the which one? Statins. Yeah, next here, types of statins. Here some types of statins or some classification of statins we will discuss here. The first one is lovastatin, then simvastatin, atorvastatin, rosuvastatin, pravastatin, pitavastatin. Okay, in our day-to-day life we are very familiar with this lovastatin or atorvastatin, then rosuvastatin. These are three important drugs rolling in the market. The first one here is a precautions and contraindications for the statins. What are the precautions? See, breastfeeding you cannot give for the breastfeeding mothers this statins. Then high alcohol intake, drinkers you cannot give. Then myopathy, then increase in liver enzymes. If liver enzymes are increased means then you cannot give these statins. Then active liver disease or persistent abnormal liver function test. If the patient is suffering from liver cirrhosis means at that time also you cannot give. And in the pregnancy also you cannot provide the statins. These are some precautionary measures and contraindications you have to keep in mind. Next, let's discuss about the pharmacokinetics of the statins. How the statins shows their pharmacokinetic. See, most statins have high first pass clearance by the liver, means they will metabolize in the liver only maximum. Then greater than 95% of these drugs are bound to plasma proteins with short half-life. They directly go and bound to the plasma protein. Then drug-drug interaction involves specific interaction with the cytochrome P450 drug metabolism system, especially cytochrome CYP34A. Just means drug interaction involve, where the drug interaction mainly involve with the cytochrome P450 drug. If that drug contain the cytochrome P450 means then that leads to the interactions, drug interactions. Either they will increase the effect of the statins or they will decrease the effect of the statins. Then next point, all statins are taken orally at bedtime because of the hepatic cholesterol synthesis is maximal means maximum between midnight and 2 a.m. See, this is very important point. You have to remember statins are always preferred for the night only, because there I have told you cholesterol is synthesized at night only, so we are giving this at night. So except atorvastatin taken at any time because of its long life, means it having the 14 hours of its action, long life action. So for that reason atorvastatin, it is one drug we can take it in any fashion, means in any time, morning, evening, night. Okay, yes, this is the pharmacokinetic. Next, adverse drug reaction. What is the, some adverse drug reactions are there? Example: kidney injury, liver damage, neuropathy, memory defects, acceleration of the aging, infection and cancer may be caused by these drugs. Diabetes, increase in the liver enzyme. These are the some adverse effects. See, if they ask pharmacology, means you remember one thing. First you write what is the disease, the name of that disease. Okay, now calcium channel blockers. Why we are giving that called calcium channel blockers? First you write that. Afterwards you go through the types. If they are having the types, means classifications, means you can classify those. Okay, after the classifications you go for the mechanism of action. This is very important. First pharmacology start with the mechanism of action. After writing the mechanism of action, you go through the pharmacokinetic. It is very important. After pharmacokinetic, you can write some of the adverse effect of that particular drug, or you can write contraindications or precautionary measures. These, if you follow this pattern, means it's better, and it all according to the Pharmacy Council of India, this is the best passion to mention the pharmacology of any drug. Now, pharmacology of the calcium channel blockers, what does it say? See, it is also known as a calcium antagonist. Antagonist means they will oppose the action of the calcium, means they will suppress the calciums. Clear? Then prevent calcium from infiltrating the cells of the heart and the blood vessels. Just they will infiltrate, means they will prevent calcium from infiltrating the cells. Okay, maximum level of calcium if get liberated from the heart vessels, means that leads to the either increase in the BP, blood pressure. So what they will doing means they are preventing this infiltration of the calcium level. The next one is relaxes and widens blood vessels of the heart within the arterial walls, promoting lowered blood pressure. What they are doing, they are relaxing the blood vessels of the heart so that your blood pressure, your BP can get lower. Then the next point is may also show the heart rate, relieve chest pressure and control an irregular heartbeat. Yes, they are first line antihypertensive drug. Which one? These calcium channel blockers. These are the first line antihypertensive drug. If anyone suffering from this type of the increase in the BP, means first we are giving this type of the drugs. Means which one? Calcium channel blockers. Then the onset of antihypertensive action is also quick here. Okay, you just remember all this point. Whatever you know, you write in the introduction. No worry. Okay, then monotherapy with CCBs is effective, is about 50% of the hypertensive patients. Then can also be used for the treating angina. If a patient is suffering from the chest pain, you can give this type of the calcium channel blockers. Yeah, next one is the classifications of the CCBs. CCBs means calcium channel blockers. See, dihydropyridines, then benzothiazepines, phenylalkylamines. These are the three important classifications. Dihydropyridines, in that nifedipine, amlodipine, then felodipine, clevidipine. You are observing the suffix here, dipine means dipine. You remember these all things. If dipine ends, means if the drug ends with the ine, dipine means then those are calcium channel blockers. Are you getting? Next one is benzothiazepines. See, phenylalkylamines, deletism, verapamil. Yeah, clear. Next, what is the mechanism of action of these calcium channel blockers? Suddenly, if you don't know anything, means you write this one. Sir, actually what happens in the calcium channel blockers, they will relax the heart vessels, they will relax the vessels, and they will inhibit the secretion of the calcium. Enough. Don't take any hesitation or don't worry. Just write this one. They will inhibit the calcium level, they will relax the heart vessels. Finish. Automatically your BP get reduces. Then CCBs means calcium channel blockers, block voltage sensitive L-type calcium channels by binding to a specific site on the alpha A subunit. Then prevent entry of calcium into the cell, no excitation coupling reaction in heart and vascular muscle and vascular smooth muscles. Means there is no excitation. No excitation means no excess secretion of the calcium. No excess secretion of the calcium leads to decrease in the blood pressure. Simple. Pharmacokinetic. What does it say? See, well absorbed through gastrointestinal tract. If you take this orally, means it is well absorbed. Then first pass metabolism is common, highly bound to plasma proteins, metabolized in the liver. Okay, because of the first pass metabolism, it metabolizes in the liver. Next, excreted through urine. See, all these calcium channel blockers, they are excreted through urine, not by the fecal. Very less drugs they will come out from the fecals, but here maximum drugs they are metabolized in the liver and excreted through the urine. Then uses of the CCBs, see, angina pectoris, supraventricular arrhythmias, then hypertension, migraine, then Reynolds phenomenon. Yes, these are the some example. Adverse effects, the postural hypotension, palpitation, reflex tachycardia, edema, dizziness, constipation, sedation, headache, fatigue. If you don't know anything, means you remember headache, fatigue. Then if you are giving the any type of the antihypertensive drug, means you remember there is some patient will suffer from direct low BP, means suddenly fall in the low BP, so you can write that side effect. Then edema also it is a common, dizziness also it is a common. Contraindications means for whom we cannot provide these, like heart failure patients you cannot give these all. Then bradycardia patients, okay, bradycardia means if they are having the low heart rate, means for them you cannot supply these. Then anteroventricular block, okay, these are the simple contraindications whom you cannot give. Next, pharmacology of the hydrocortisone. See here, after second, actually third question should become, but here the questions are some, means the question numbers are in some wrong pattern. So you forget that, it is the minor mistake, just question numbers are in wrong pattern, adjust for that. Fourth one, pharmacology of the hydrocortisone. I have told you, hydrocortisone, what is this? It is a glucocorticoid used to treat corticosteroid response to dermatosis, endocrine disorder, immune conditions and allergic disorders. See, one point I will tell you, you remember this one, because while you are working in any type of the medical shop, see, every doctor in today's generation, they are giving the steroids. Why they are giving the steroid means, see, steroid what they will do, they will increase the immunity of the human body. Okay, means intentional increase in the immunity, excess increase in the immunity by these tablets. Okay, automatically if your immunity increase, means what happens, all the antigens will die, means outer body particles will die. How? By the increase in the immunity of your body. So this hydrocortisone, this is the major use why their doctors are prescribing but very severe side effect. If you take this for the long duration, it leads to the osteoporosis, very dangerous disease, very dangerous disease, and sometimes it leads to the major kidney, major liver failures. Yes, this is a simple story of the hydrocortisone. Any steroid you take, they are very dangerous, so please don't prescribe these steroids. Okay, if the patient is not curing, at that time you can prescribe with the help of the doctor. Yeah, the classification, see, some of the classifications are there. That is natural, you know that in our body, mineralocorticoid, glucocorticoid, these are natural. Aldosterone, it is a mineralocorticoid. Hydrocortisone, it is a glucocorticoid. Now see some of the short acting steroids like hydrocortisone, means 8 to 12 hours. Intermediate acting prednisolone, then triamnicolone, long acting dexamethasone, betamethasone. Clear? Then now inhalation, then fluticasone, budesonide, beclamethasone, then clobetasole, mometazone, desonide. Mineralocorticoid, fludrocortisone, cortisone, if you observe me, that is a steroid. Yes. Next one is a mechanism of action. The short term effects of the corticosteroids are decreased vasodilation and permeability of the capillaries, as well as decreased leukocyte migration to sites of inflammation. What they will do means, these steroids, they will inhibit the leukocytes migration to the inflammation. If any inflammation happen, means our body has one system. Okay, anything happens in the body, inflammation or wound, means all the WBC will go and sit there. So this what they will do, they will prevent here by going. No, they won't allow us to go to the inflammation side. They will act inside the body only. Okay, they will prevent that leukocytes WBC going to the inflammation site. They will prevent that, and except that what they will do, they will directly attack to those foreign particles. This is the one major vital role of these steroids. Next is corticosteroids binding to the glucocorticoids. receptor mediate change in gene expression that lead to multiple downstream effects over the hours to days. Means they will just change the gene expression. For that reason, these steroids are very dangerous. Yeah. Yes. Next one is some of the indications. What is the indication? Means you can give for the patients. There's those who are suffering from the rheumatoid arthritis or osteoarthritis and rheumatic fever, gout, then severe allergic reactions. Okay, then also it is a drug of choice in anaphylaxis. Anaphylaxis means some patients what they are suffering from is severe lung disease. Means they cannot able to breathe. At that time we can give this prednisolone or any type of the steroids. Then autoimmune disease like lung disease, bronchial asthma, COPD, pulmonary edema, then for lung maturation. Okay, then infective diseases or fungal infection. Okay, normally we are prescribing this type of the steroids to increase the immunity. Next is adverse effect. See sodium and water retention, edema also, then hypocalcemic alkalosis, progression, rise in blood pressure. These are some adverse effect. Precautions and contraindications. Peptic ulcer patients we cannot give. If they are having diabetes mellitus, we cannot give. Hypertension, no. Then fungal infection also, viral and fungal infection we cannot give this. Okay, see for some fungal infections you can give, but severe fungal infection you cannot give. No. So it is contraindicated. Tuberculosis, then osteoporosis, herpes simplex keratitis you cannot give. Then psychosis, epilepsy, CHF, renal failure. These all are the contraindications. But in today's generation, maximum they are giving in TB also. They are giving in which one? Viral and fungal infection also. The market is giving in then peptic ulcer also. They are following because to increase the immunity. Okay, if the patient get recovered in 5 days means normal taking dose. If we given this type of the steroids means the patient will wake up only in 2 days. Why? Steroids. Then route of elimination. See, corticosteroids are eliminated predominantly in the urine only, and however data regarding the exact proportion is not readily available here, but drugs are eliminated in the urine. Half-life is 2.15 hour. Clear? Next, oral hypoglycemic agents. Yes, hypoglycemic agents, one of the very trending medicines, drugs in our day-to-day life. Hypoglycemic agents, the drugs which are used to lower the blood sugar level, that we are called hypoglycemic agent. They are used to treat the diabetes mellitus. Clear? And diabetes mellitus is characterized by the persistent hyperglycemia, usually with glucosuria. Means they are increase in the glucose level. Clear? The lack or deficiency of the insulin affects carbohydrate, protein, lipid metabolism. As a result, the different symptoms observed are that hyperglycemia, glucosuria, then ketoamine, ketonuria, then hyperlipidemia, polyuria, then polydipsia, increase the thirst. Okay, these all are the some of the diabetes mellitus introduction. Clear? Mainly diabetes mellitus is observed in the patient those who are unable to secrete the appropriate amount of insulin in the body. The major reason is here, this one. They are unable to produce the appropriate amount of the insulin. Now some of the classifications are there for this diabetes mellitus. Sulfonylureas, this only I am going to tell you. See, if they ask sulfonylureas or glibenclamide, say. In sulfonylureas, some of the first generations are there. For an example, talbutamide, then chlorpromide, acetohexamide, then tolazamide. The second generation, glibenclamide, glipizide, gliclazide, then glimepiride. These all are the some of the sulfonylureas. And sulfonylureas, it is the most selling brand in India. Not only in India, in world, sulfonylureas. Then next classification is biguanides. Biguanides, it is also one of the very selling brand, that is a phenoformin, metformin. These are the two examples. Then meglitinide analogs, example here meglitinide analogs, ripaglinide and netiglinide. Then thiazulinidiones, rosiglitazone, then pioglitazone, then alpha glucoside inhibitors, acarbose and miglitol. Okay, you can remember any one or any 2. If you can able, you can remember 2, but it's 1 is enough. Okay, 1 is enough. But very important are here first and second generation of the sulfonylureas, biglutenides and meglitenide analogs. These are very important. Yes, mechanism of action. They will increase uptake and utilization of the glucose by skeletal muscles. What they will do means these all sulfonylureas you take or any type of the hypoglycemic agent, what they will do means they will uptake and utilization of the glucose. Okay, excess glucose presence in the human body, no, that they will uptake means they will receive where in the skeletal muscles, which reduces the insulin resistance. Then inhibition of the hepatic and renal gluconeogenesis. They will stop the gluconeogenesis. Means gluconeogenesis means synthesis of the new glucose from the non-carbohydrate, like from the lipid. What they will do, they will stop these all, means they will prevent the synthesis, which decreases hepatic glucose output predominantly. They slow down the intestinal absorption of the glucose. They will slow down. If intestinal means villi are present on the intestine, that villi what it will do, with the help of the some of the transformers, they will accept those all glucose level and send into the blood circulation. Okay, that leads to the increase in the blood glucose level. So these villi or these small intestine, they will prevent the absorption of the glucose. They will close their receptors. This is the simple mechanism of action for all type of the oral hypoglycemic agents. Only tablets I am telling, not insulins. They are having the other mechanism of action, like you are using that human mixtard, human actrapid, those are modified from the RNAs. Okay, yes, next one is pharmacokinetic. Administered just before or along with meal. Yes, moderately protein, they will bond with 70 to 80% protein bonding is there. Metabolized in the liver, few are metabolized to activate metabolites, means low volume distribution is there. Then few secreted unchanged in the liver, no changing, they directly secreted in the liver. Few excreted unchanged in the liver. Adverse effect, hypoglycemia. Long acting drugs dangerous, they will can lead to the some of the hepatic disease or renal disease. Then GIT disturbance, weight gain, allergy, thyroid disinfection, these are the some of the adverse effects. Next one is the pharmacology of the prednisone or prednisone. These are the synthetic steroids. Synthetic means man-made steroids. First one, what are these steroids? Steroids is a class of drug called, means prednisone is a class of drug, they are known as steroids. Prednisone reduces swelling and decrease the body's ability to fight infections. Okay, they will reduce the swelling. They will decrease the swelling. And what they will do means excess of the body's immunity, wasting in fighting with the infection, excess. So what they will do, they will reduce that excess fighting with the infections. What amount is required, no, only that much amount is deliberated to fight with those foreign particles or infections. Okay, this one very important point. Then prednisone is used to treat many different conditions. It is used to treat endocrine disorders when the body does not produce enough of its own steroids. Then it is also used to treat many disorders such as lupus, arthritis, severe psoriasis, then severe asthma, ulcerative colitis and Crohn's disease. Mechanism of action of this prednisone is in part. Prednisone act as an immunosuppressant. You remember this one. Immunosuppressant. They will suppress the immunity. Okay, means that only suppress the immunity means what we studied, no, just definition of the prednisone introduction. Excess of the immunity, they will suppress this one to fight with the infection. Suppress, immunosuppressant. Give an example for immunosuppressant, prednisone. The immune system protects you against foreign bacteria and viruses. Everyone know this one. And in some illness, the immune system produces antibodies that become overactive and cause undesirable effects. In some conditions, what happens? Your body, what happens? They will produce some of the antibodies, and they become overactive and they leads to some of the undesirable effects. These illnesses are referred to as autoimmune disease. Yes, if your immune system get overactive or over excited means at that time this autoimmune disease will takes place. Autoimmune disease means your immunity, what it will do means it will kill your own healthy cells, that leads to the autoimmune diseases. These killing of the own healthy cells was prevented by the some of the steroids. Remember this one, simple point. Prednisone suppresses the production of the antibodies. Yes, if no antibodies means no autoimmune diseases or no autoimmune suppression. Yeah, not suppression, no autoimmune excitation. Yes, this suppression can make it slightly harder for you to fight off infection. Yes, but also stabilize the immune system. If it is overactive, you can stabilize that one. Prednisolone also works against inflammation to reduce the heat, redness, swelling and pain. These are the some of the common mechanism of action of the prednisolone. Then pharmacokinetics, cortisol is bound to the corticosteroids binding globulin. Then corticosteroid binding globulin is increased by the estrogen, decrease in the cases of liver cirrhosis and nephrosis of the kidney. Then the half life of this prednisolone is 90 to 110 minutes, approximately 2 hours half life. Metabolized in the liver, excreted by kidneys as water soluble reduced conjugates. About 10% is excreted as 17 keto steroids. Simply remember, if you are taking the steroid means you have to drink lots of water. Otherwise what happens, you will get the pelvic pain. Yes, severe pelvic pain you will get. So if your doctor prescribe this steroids means you take the steroids with the excess of water. Remember this point. Then contraindications, who should not take this prednisolone means do not take prednisolones if you are serious bacterial, viral or fungal infection. See, I have told you, serious. Prednisolone weakens the body's immune system and thus its ability to fight the infection. So if the severe infection is there, you just leave that. And before taking this medication, tell your doctor if you have kidney disease, liver disease, high BP, ulcerative colitis, then hypothyroidism, any psychiatric conditions, then any type of the diabetes mellitus, type 1 or type 2, just these all are contraindicated. Side effects of this prednisolone, some side effects. See, acne or hair growth, then the thinning of the skin, glaucoma, osteoporosis, roundness of the face, then changes in behavior. These are the some side effects of the prednisone or the steroid. Now the loop diuretics. See, some questions what we discussed now in 5 marks. Now what we are discussing now. Same the repeated where in the 10 marks. There we discuss some of the diuretics, loop diuretics we discussed. Okay, sparring diuretics we discussed. Okay, then thiazide diuretics we discussed. Some of the diuretics we discuss in the 10 marks. Clear? Then here the loop diuretics. Loop means you know that ascending loop and descending loop. These drugs what they will do, loop diuretics, they will remove the water, sodium, potassium from the loops. Simple. These are the loop diuretics. Simple mechanism of action. Remember this one. Yeah. Definition, these are drugs which cause a net loss of the sodium and water in urine. What they will do? They will remove the sodium and water in the urine. Then there are several categories of diuretics. All diuretics increase the excretion of the water from the body. Diuretics. What they will do? Water is excretion from the body. They will increase the water excretion from the body. And diuretics are very, very preferred in the patient, those who are having edema, either pulmonary edema. Okay, it is a drug of choice in pulmonary edema, or some of the hypertension also we are giving this diuretics. Because of if water get excreted means what happens? BP get decreases now. Diuretics. Then pharmacokinetics, the loop diuretics are rapidly absorbed. They are eliminated by the kidneys by glomerular filtration. Absorption of the oral torsemide is 1 hour. Oral absorption is nearly as complete as with the intravenous administration. Means we are same, both intravenous administration and administration and oral absorption, they are completely nearby. Okay, both are same. If you given the oral route also, the action is same. If you given by intravenous IV means the action is same. But the patient is very important here. If the patient is bedridden, at that time you have to supply the IV route. If the patient is well and good, then no problem, oral route is best. Then the duration of the effect for furosemide is 2 to 3 hours, and for torsemide is 4 to 6 hours. Then loop diuretics, see some of the classifications are there for the loop diuretics. Highly efficacy diuretics. Okay, they will inhibit the sodium, potassium and chloride co-transport. Sulfonyl derivatives like furosemide, then bumetanide, then torsemide. Then phenoxyacetic acid derivative, that is derivatives ethacrinic acid. Then pharmacology, simple pharmacology or mechanism of action of this loop diuretics, what they will do means, loop diuretics acts on NKCC2. Now what is this NKCC2? N means sodium, K means potassium, CC2 means 2Cl chloride molecules. These loop diuretics, they will act on the sodium, potassium and chloride. Okay, symporter in the ascending loop of the Henleys. Okay, one is descending and one is ascending. They will act here, ascending loop. By competitively binding to chlorine binding sites, they will just go and bind to the chlorine, means chloride binding site. They inhibit. What they will do? They will stop the sodium, potassium, chlorine reabsorption. Okay, and thus causes their elimination in urine along with water and other ions. See, actually what happens, these loop diuretics, what now discuss, see here at ascending loop or descending loop. Here what happens, some of the absorptions capacities are kept here, means they will absorb some of the water level, some of the potassium, calcium, not calcium, potassium, then sodium, then water molecules. What these diuretics will do means, they will inhibit this absorption by these ascending or descending loop. If not absorbed means what happens? They will just excrete it in the form of urine. Okay, that leads to the, means this is the simple mechanism of the diuresis, increase in the production of the urine. Next, uses hypertension we are giving, then edema like pulmonary edema, cardiac edema, pedal edema, hypercalcemia, then renal caliculi means stone in the renal capsule or in a kidney stone, what you are telling, no, just to remove that we are using this type of, not in some many cases, but in some conditions we are giving this one. Side effect like hypokalemia, gout, then hyponatremia, then hypocalcemia. This calcium level get decreases, then potassium level also get decreases, sodium level also get decreases. Why means, because of excessive use of this loop diuretics. Yes, the next question is the 7th one, that is pharmacology of a propyl thiouracil. So this propyl thiouracil actually this is the anti-thyroid drugs. Clear? Let's study about this drug, that is a propyl thiouracil. See, first point, these are drugs used to lower the functional capacity of the hyperactive thyroid gland. You all know that our thyroid gland, they will secrete T4 and T3 cells. If these T3 or T4 cells get secreted excessively, then there is a chance of hyperthyroidism. So to prevent this hyperthyroidism, we are giving some of the anti-thyroid drugs, means they will inhibit the synthesis of the T4 and T3. Okay, among that anti-thyroid drugs, one of the very advantageous and very super marketable the anti-thyroid drug is this propyl thiouracil 1 and Carbimazole. These are the two. One is Carbimazole and propyl thiouracil. Okay, first we will discuss here about the propyl thiouracil. See, one more very important thing here is thyrotoxosis is due to the excessive secretion of the thyroid hormones. Okay, that leads to the some of the Graves disease, that is autoimmune disorder, and toxic nodular goiter are two main causes. Yes, you know these simple one. Here the classifications of the anti-thyroid drugs are, say, hormone synthesis inhibitors. Actually, the anti-thyroid drugs, the first classification is they will inhibit the hormone synthesizes, that is a propyl thiouracil or Carbimazole, methimazole. Okay, zole thiouracil means these will stop the synthesis of the thyroid. Means T3 and T4 cells. hormone release inhibitors like iodine, iodides of sodium and potassium, organic iodide. Then destroy thyroid tissue, that is radioactive iodine. Okay, very very less preferable this one. Then inhibit ionic trapping, that is percolates, then pertechnetate, then thiocinates. But most probably we are using these two. One is a hormone synthesis inhibitors, then hormone release inhibitors. Clear what I am telling? Then mechanism of action, simple mechanism of action of these thiouracil or the anti-thyroid drugs. See, propyl thiouracil, what they will do means simply they binds to thyroid peroxidase, okay, and thereby inhibits the conversion of iodide to iodine. See, actual what happens, the iodide it is in inactive state. So these propyl thiouracil, what they will do, they will bind to thyroid peroxidase and there will inhibits the conversion of the iodide to iodine. Okay, means iodide it is an inactive state. If it converted to the iodine means it becomes active, means which leads to the increase in thyroid gland. If the thyroid in the iodine only means iodide only means then there is no problem, means there is no secretion of the this T3 or T4 cells. When the thyroid is in iodide form, means the hormone is in iodide form. If it converts to the iodine means yes, obviously it increases the thyroid hormones. So they will inhibit this conversion. Who will inhibit this conversion? This propyl thiouracil. By how? By binding to thyroid peroxidase. Understand what I am telling? Example, you have know that thyroid, many examples are there. Propyl thiouracil, the drug you will get in the market. Then thyroid peroxidase, normally what they will do, they will convert the iodide to iodine via hydrogen peroxidase as a cofactor and also catalyze the incorporation of the resulting iodide molecule onto both the 3 or 5 positions of the phenol rings of the tyrosines found in thyroglobulin. These all complication no need to remember, just to remember only this one. See, propyl thiouracil, what they will do, they will bind to thyroid peroxidase and they will inhibit the conversion of the iodide to the iodide to iodine. This is the simple enough one. Okay, if you try to remember excess thing means you will forget everything. Now pharmacokinetic, very simple pharmacokinetic. See here, propyl thiouracil is readily absorbed and is extensively metabolized in the liver. Approximately 35% of the drug is excreted in the urine and within 24 hours it gets excreted. Next is a half-life of this propyl thiouracil is 2 hours. Then pharmacology of the furosemide, very important drug, furosemide. Furosemide, what is this? Furosemide, it is the means diuretic, it is one of the diuretic. Okay, that is a loop sparing diuretic we can call. Introduction, furosemide is a loop diuretic, okay, that prevents the body from absorbing too much salt, allowing the salt to instead to be passed in urine, means they will reduce the collection of the salt. Okay, instead what they will do, they will liberate or they will excrete the sodium ions water excessively in the form of the urine. Clear? Then furosemide treats fluid retention, that is edema, swelling of the legs. Okay, you know that due to this fluid retention, that is edema, swelling of your legs, hands, faces, in some of the people, those who are suffering from the kidney failure or some they are suffering from liver failure. Okay, they are especially having this type of the problems. See, congestive heart failure, liver disease or any kidney disorder, nephrotic syndrome. This medication is also used to treat a high blood pressure. You know that furosemide, it is also used to treat the hypertension. Yes. Next one is see, this is the introduction. Mechanism of action, simple mechanism of action here. Inhibit the co-transport of the potassium chloride in the luminal membrane of the ascending of the Henle's loop. Therefore, reabsorption of these ions is decreased. Very simple. What we saw in the which one, loop diuretics, no, same you have to write the mechanism. Just what they will do, they will inhibit the absorption of the sodium, potassium ions, water from the ascending loop. These all get decreased automatically. If they get decreased means what happens, these all ions will get excreted in the urine. Okay, there is no chance of collection of these ions. If there is no collection of these ions, there is no chance of deposition of these ions in the body. If no deposition, no swelling. If no swelling, means that is no edema. Clear? No hypertension. Simple one. Then therapeutic use, a drug of choice for the reduction of the acute pulmonary edema of the heart failure. In acute pulmonary edema, because of the rapid onset of the action, particularly when given intravenously, therefore it is used in emergency cases only. Clear? Then next point is hypocalcemia treatment along with hydration is also used for the treatment of the hyperkalemia. Okay, if excess of the potassium is present, means to remove that potassium, what we are giving? We are giving this furosemide intravenously. Okay, intravenously. But remember one point, one contraindication is there, very danger contraindication. See, if your BP, blood pressure is only, now see, actual blood pressure is 80 by 120. Okay, 80 is a diastole, 120 is systole. If diastole pressure is 60, okay, D diastole, then systole pressure is 120 is approximately, that is 100, then you cannot give this diuretics. Okay, because there is a chance of low BP. If it comes to 30 means, and if it comes to 70 means, then there is a chance of a very less to live in this world. Very dangerous to live in this world, means death occurs most probably in these cases. So the doctors always will check the BP before giving this type of the diuretics, either loop diuretic or loop sparing diuretics or thiazides, any type of the diuretics. They will check the BP of the particular patient before giving this diuretics. Yeah. Then pharmacokinetics, absorption, see, 60 to 67% absorbed after oral administration. Then simple. Then distribution, they will crosses placenta, enters into breast milk. So it is very dangerous to give to the pregnant lady, or it's very dangerous to give to the milk feeding mothers. Then protein binding, 91 to 99%. Metabolism, minimal metabolized by liver. Then some non-hepatic metabolism, excretion via kidney, half-life is 30 to 60 minutes. Okay, adverse effect is ototoxicity, hyperuricemia, then acute hypovolemia, potassium depletion, then hypomagnesemia, then hypokalemia, allergies. Okay, those who are having allergies for this furosemide, they are not taken this tablet. Contraindications, diuretic hypersensitivity patients, then electrolyte imbalance, then hyperglycemia patient, means glycemia, high glucose level, no, not allowed. Then ventricular arrhythmias, means if they are having any sort of the bradycardia, no. Then acute myocardial infarction, no, here also it is contraindicated. Then hypotension also it is contraindicated, I have told you that one. Yeah, these all are the furosemide tablet pharmacology. Then our 9th question is a pharmacology of the heparin, one of the very important anticoagulant. Okay, blood thinner. In our world we will call it as a blood thinner. It will thin the blood, heparin. And this heparin, it is a naturally produced in the human body. If it fails to produce naturally in the human body, we are giving intravenously heparin. Low molecular weight heparins are available in the market, and it is only in the form of either intramuscular veins, means intramuscular routes, or in the intravenous routes. They are not through the oral route. Okay, only intravenous or intramuscular route. Then what is heparin? See, heparin is an anticoagulant, blood thinner, that prevents the formation of the blood clots. Then heparin is used to treat and prevent blood clots in the veins, arteries, or lung. Heparin is also used before surgery to reduce the risk of blood clots. Then heparin mechanism of action, the anticoagulant effect of heparin is mediated via antithrombin 3. Okay, how this anticoagulant, means heparin, how they will act? They will just mediated via antithrombin. Okay, then antithrombin inactivate thrombin. Actually, this thrombin, what is this? Thrombin, it forms the clot. Okay, if any blood oozes out from your body, means you know that there is a formation of the fibrin threads. That fibrin threads is formed due to this thrombin. Okay, these thrombin is prevented or inhibited by the antithrombin 3. Clear? This is one of the essential for clot formation. Which one? That is thrombin. So this thrombin is inhibited by which one? Antithrombin 3 and other serine protease like clotting factors 7, 9, particularly 10A. 10A, yeah. In the absence of the heparin, this inactivation is slow. If heparin is not present, means this type of the inactivation is slow. So heparin acting as a cofactor accelerates the reaction by 1000-fold. Means if heparin is absent, means there is a formation of the clot. Means these antithrombin they won't act in the absence of the heparin. So we are giving external heparin for that patient. Simple words. Next, pharmacokinetic absorption. Heparin is not absorbed from the GI, means gastrointestine we cannot. Then most be given by IU or subcutaneously. It absorbed from the intestine. Metabolism, the liver, adreno-coloendothelial system are the sites of a biotransformation. Elimination, the average half-life is 1.5 hours and the dose dependent excreted in the urine. Yes, clinical uses: venous thrombosis and pulmonary embolism, unstable angina or acute myocardial infarction during and after coronary angioplasty or stent placement. Okay, stent in heart, stent are placing. At that time also we are giving this anticoagulant heparin. Low dose heparin in preventing the venous thromboembolism. Okay, yes, adverse effect is bleeding. Bleeding is one of the common here. Okay, bleeding, that is and one more very simple type of the side effect is a mild elevation of the serum level. Osteoporosis, this one is the osteoporosis. This is the healthy bone. If regular use or the long term use of heparin leads to the osteoporosis. Then the hyperkalemia, excess of the deposition of potassium. Then allergic reactions. Simple. See, actually how clot occurs? Means anticoagulant means how the clot can be disappears. How? By use, main important is potassium here. If potassium is absent in the body, means then what happens? There is a formation of clot. Everywhere you will get clot, clumpy. Why? Because of potassium, absence of potassium. If present of potassium means no problem, there is no clotting of the blood. Why? Because means potassium, it is the precursor for the heparin. Clear what I am telling? Potassium is very important. So eat as much as carrot. As much as you can, you eat the carrot. Carrot is very rich in potassium. Yeah, and also that banana. Yes, banana also very rich in potassium. Contraindication: bleeding disorders, then severe hypertension, ocular or neurosurgery. Yes, these all are the contraindications. Yeah, our next question is pharmacology of the prostaglandin. One of the very important question asked many times in our examination, this one. Clear? Now what does it say? See, first you understand what is this prostaglandin. See, my dear brothers and sisters, so prostaglandin, it is a chemical or a hormone that is secreted inside the human body. Okay, if any inflammation is occurred in your body, means that is due to the secretion of the prostaglandin. Or if you are observing any pain, okay, that pain is due to the secretion of the prostaglandin. Clear? Prostaglandin, these are the cytochrome type of the hormones. Okay, if you are feeling too much of the pain, leg pain, hand pain, headache, why? Because of the secretion of the prostaglandin. Okay, yeah, some of the NSAID we are giving, no. Why the NSAID means the non-steroidal anti-inflammatory drug like your ibuprofen or paracetamol, aceclofenac, diclofenac, okay, naproxen, nimesulide. These all are the NSAIDs. Okay, what they will do? They will inhibit the action of the prostaglandin. Yeah, yes. Now prostaglandins are extremely potent biological active lipid mediators that are synthesized throughout the body. Prostaglandins have diverse hormone-like effects in animals and they are derived enzymatically from the fatty acid, that is arachidonic acid. They are derived from the arachidonic acid. Very important, this one. You remember this one, arachidonic acid means these are derived from the fatty acid arachidonic acid. Next, pharmacological action of this prostaglandin. See, in a cardiovascular system, what these they will do means prostaglandin enzyme 2 and prostaglandin factor 2, they are potent vasodilator than acetylcholine or histamine. You know that histamine or acetylcholine, these are the vasodilators, they will dilate the vessels, clear. And these prostaglandins, they are more potent than these type of the vasodilators. And this prostaglandin consists of many larger veins including pulmonary vein and artery. Okay, then fall in BP occurs when prostaglandin is injected, that is, but prostaglandin has a little effect on BP. If fall in BP means because that the reason for the decrease in BP, that is of prostaglandin. Okay, this is the mechanism of action. Now platelets, what is the pharmacological action in the platelets? See, prostaglandin, okay, that is prostaglandin is found in the vascular endothelium and is a potent vasodilator and inhibitor of the platelet aggregation. Okay, see here, prostaglandin, what it will do, it will prevent the aggregation. Aggregation means clumping. If clumping of the platelets found means what happens, so that leads to means clotting. Okay, inside the clotting, inside in the human body, if inside clotting occurs means what happen, there leads to some of the heart diseases or any type of the diseases will occur. Why? Because of the aggregation of the platelets. Then pharmacological action of these prostaglandin in the GIT, that is a gastrointestinal tract. See here, they increase the intestinal motility. These prostaglandin, what they will do? Movement of the food inside the intestine get increased. Then prostaglandin inhibits gastric acid secretion and they also stimulate intestinal fluid secretion resulting in diarrhea. Yeah, clear. They will inhibit the excess gastric acid secretion and they stimulate the intestinal fluid. Okay, in the diarrhea, what happens due to the continuous diarrhea, there is a chance of dehydration. So to maintain that dehydration, these prostaglandins play a vital role. They will collect the water and store. Are you getting? Yes. Then prostaglandin, they will increase the water, sodium, potassium excretion and have a diuretic effect also. See, they are having the diuretic effect also. They cause renal vasodilation and inhibit tubular reabsorption. They will stop the reabsorption. If the reabsorption of the water, reabsorption of the sodium, potassium inhibits means obviously it acts as a diuretic. Which one? Diuretic. So we got here one thing, prostaglandin, it also acts as a diuretic. It acts as a vasodilation. Okay, it helps to maintain the hydration in the body. Clear? Then biological function, maintenance of the intraocular pressure, then vasodilation or vasoconstriction, cause aggregation or disaggregation of the platelet, they will regulate the inflammation, then induce labor. Okay, in pregnant mother, it helps to induce the labor, means fast delivery. Okay, then act on parietal cells in the stomach wall to inhibit the acid secretion. Yes, increase glomerular filtration rate, then sensitize the spinal neurons to pain. Yes, if spinal neurons are there means they will sensitize to them. Then inhibitors, yes, prostaglandin, if it secrete excessively means that leads to very danger, means you will suffer from a severe pain if it is in excess amount. So some of the inhibitors of the prostaglandins are there, that is NSAID, they will inhibit the cyclooxygenase. Some of the corticosteroids are there, and COX-2 selective inhibitors, that is celecoxib, used to treat arthritis pain and rheumatoid arthritis. Yeah, these are the some pharmacology of the prostaglandin. The next the question is classify antihistamines. Yes, here antihistamines, you know that what are these antihistamines? Antihistamines are the amines. These are the amines which helps to inhibit the excess secretion of the histamine. Okay, if excess histamine secreted means what happens, there is a condition that is known as allergic condition or anaphylaxis will be occurs in some condition, but basic here is excess of Histamine leads to allergy or acidity problem, headache problem. These are some common side effects. And what is this antihistamine? See, a drug means this antihistamine drug reduces or eliminates the effects mediated by the chemical histamine. Okay, the histamine chemical, they shows some of the effects. That effects is reduced by this antihistamine. Simple definition. And histamine is released by your body during an allergic reaction and acts on specific histamine receptors. Actually, if histamine release means what happens? Means in allergic conditions this histamine get releases. The term antihistamine usually refers to H1 receptor antagonist. Actually, that is inverse agonist. Okay, that is antihistamine. These are the H1 receptor antagonist, opposite action. Antagonist, receptor antagonist. They go and bind to the receptors and they will stop the secretion of the histamine. Okay, if histamine secreted means there is no allergy. Okay, actually, why histamine is secreted? Histamine gets secreted means the patient is suffer from the allergic reaction. If histamine stopped means no allergy or no burning sensation or no excess amount of secretion of the gastric acids. Yeah. Next, antihistamines. This point, antihistamines compete with histamine for binding sites at the receptors. Antihistamine cannot remove the histamines if it is already bound. Very important. See example. Now these are the histamine site, histamine receptors. These. Now see this molecule. What is this? This is the histamine. Now actually, if the histamine go and already bound to the histamine receptors, then these antihistamines can't go and release this one. They can't. They are not having the ability to remove the histamine from the histamine receptor. No. But see here it is also one histamine. Now what these antihistamine they will do? They will inhibit this one. This will. These will inhibit this histamine. Okay. If already it get occupied in the receptors means at that time no. Okay, before the acquiring of the histamine into the receptors means yes, obviously it can stop that, it can inhibit. After the jumping to the receptors, no, that is not possible here. Now classification of the H1 antihistamines, we already discussed these histamines where in our which one, that 10 mark question. See, highly sedative, that is a diphenhydramine, then a dimenhydrinate, promethazine, hydroxyzine. These are the some example for the H1 means that is highly sedative. Then moderate sedative, pheneramine, cynarazine, cyproheptadine, mild sedatives, chlorpheniramine, cyclazine. Then symptoms associated with histamine release. If histamine is released means what symptoms you can follow. See, one symptom is urticaria, means if the condition is mild or cutaneous, itching you will get. Okay, or erythema you will get, means that is itching you will get. Then skin mild to moderate means histamine release is mild to moderate means then the patient will suffer from skin infection, tachycardia, then dysrhythmias, moderate hypotension, mild respiratory distress. If the condition is severe, that is anaphylactic, very dangerous. This one is severe hypotension, ventricular fibrillations, cardiac arrest, bronchospasm, respiratory arrest that leads to coma or death. That is anaphylactic. It is very severe emergency situation. Next is mechanism of action. See, H1 antagonist act by competitively inhibiting the effects of the histamine. Means H1 antagonist means antihistamine drugs. They will competitively inhibit the effects of the histamine at the H1 receptor. Simple. Then H1 receptor blockade results in decreased vascular permeability. Okay, I have explained you that. If histamine get blocked means yes, there is a vascular permeability get decreases. If no vascular permeability, no histamine, no allergy. Simple. Reduction of the pruritus, then relaxation of the smooth muscle in the respiratory. See here, some patient or some volunteers, continuous cough without mucus, continuous cough. that we are telling allergic cough, what we are telling now, that allergic cough, why? Because of liberation of this histamine only, allergic cough. At that time what we are giving some of the antihistamine drugs. The best antihistamine drug, cetirizine, then levocetirizine, novel drug, second generation. You can give fexofenadine, it is the second generation novel drug, fexofenadine. Yes, you can give that one. These all are the simple but more powerful antihistamine drug that will inhibit the histamine properties. Clear? Are you getting what I am telling? Now receptors, see, some of the receptors are there of this histamine. Histamine receptors are belonging to the family of G protein coupled receptors. You are familiar with this G protein coupled receptors. Okay, they are belonging to the family G protein coupled receptors, ion channel receptors. What the receptors are there, no? In that, these histamines are the G protein coupled receptors. The subtypes of receptors, H1 receptors, H2, H3, H4. These are the 4 common types of receptors in the histamine. Okay, these are, you can see this location in brain, H1, then H2 you will get in the heart, then H3 in the CNS you will get, or gastric mucosa, then histamine receptor H4 you will get in the spleen, then T cells, okay, thymus cells, then eosinophils. Yes, then pharmacology of the glibenclamide. See, if they ask glibenclamide means you write the same, sulfonylureas they will ask means you write the same, or glipizide if they ask means you write the same. So what is this glibenclamide? It is the oral hypoglycemic agent. Let's study oral hyperglycemic agent. See, glibenclamide or glyburide is an oral anti-hyperglycemic agent. Oral anti-hyper means you can tell oral hypoglycemic agent you can tell, no problem. Okay, oral hypoglycemic agent you can tell. If you want to tell hyper means, then you have to add anti-hyper. The raised glucose level we are decreasing, no, anti, opposite. So in general you can tell oral hypoglycemic agent. Means these are the agents which reduces the glucose level. Reduction in the glucose level is called hypo. Increase in the glucose level is called hyper. Yes, it was discovered. Leave it. Sulfonylureas increase both insulin secretion and meal stimulated insulin release. See, sulfonylurea, it is a class. In this sulfonylurea class, this glibenclamide will come. Okay, these sulfonylureas, what it will do? They will increase the insulin secretion. Simple. From the alpha source. Then drug class, hypoglycemia is, then sulfonylureas, it is type 2 diabetes mellitus. Actually we are giving indications, uses, side effects, hypoglycemia, angioedema, weight gain. These are the common side effects. Sulfonylureas, mechanism of action, what they will do? They will increase the release of insulin, then decrease the production of glucose in the liver, increase the number of insulin receptors. If any oral hypoglycemic agent, if they ask the pharmacology, means the mechanism of action 90% same. Clear? Then next D point you remember here, effective only if having functioning beta cells, and side effect is hypoglycemic and weight gain. Yes, these drugs include glibenclamide, glipizide and glimepiride. If any 3 drugs asked means you write the same mechanism of action. Means these are the class of sulfonylureas. Means these drugs, they comes under the class of sulfonylureas. Next one is a pharmacokinetic of sulfonylureas or glibenclamide or glipizide or glimepiride. See, orally they are well absorbed and means 2 to 4 hours they will reach the peak, and all are highly bound to plasma proteins. Yeah, it's very important. Then duration of action is variable. Means some duration of action they can take 1 hour after the administration of the tablet. Some tablets will be after 3 hours they will show the action. It depends on the manufacturing unit. Then second generation has a longer duration than first generation. Second generation tablets, they are having the longer duration than the first generation tablets. Second generation like acarbose we are using. Some different oral hypoglycemic agents are there. Pharmacokinetic, see, metabolized in the liver, excreted in the urine. Contraindication, see, hypersensitivity we cannot give. This one is the common one. Then diabetic ketoacidosis with or without coma we cannot give. Okay, then this condition should be treated with insulin. They are having the ketoacidosis, okay, diabetic ketoacidosis, then we have to give the insulin only. We cannot treat with this type of the tablets. Then type 1 diabetes mellitus also therapy, means type 1 diabetes mellitus. If the patient is suffering from type 1 diabetes mellitus, means at that time also we cannot give this. See, for type 1 diabetes mellitus, actually the treatment of choice for the type 1 diabetes mellitus is the insulin. Okay, we have to directly give the insulin by means of the injections. That's only one and vital important treatment for the type 1 diabetes mellitus. If type 2 diabetes mellitus, means it can be prevented by using the hypoglycemic agents, type 2 one. Now ACE inhibitors, next one is ACE inhibitors, that pharmacology of the captopril. You know that this captopril, it comes under the class of the ACE inhibitor, that is ACE inhibitors. What is this ACE inhibitors? ACE inhibitors, angiotensin converting enzyme. Okay, if the angiotensin converting enzyme get inhibited, then no problem, there is a no secretion of the, means no increase in the bp get automatically decreases. Now let's study the ACE inhibitors, means the mechanism of the captopril. The ACE inhibitors lowers blood pressure by reducing peripheral vascular resistance. Then they will block the ACE that cleavage angiotensin 1 to form the potent vasoconstrictor angiotensin 2. Okay, what they will do, they will stop the conversion of the angiotensin 1 to angiotensin 2. Angiotensin 1, what it will do means, it will convert 1 into 2 with the help of this ACE, only ACE, angiotensin converting enzyme. Okay, what it will do, it will change to angiotensin 2. Why means, see, in some patients what happens, if there is a decrease in BP, okay, if there is decrease in BP, now angiotensin 1 if get converted to the angiotensin 2, means what happens here, the blood vessels get constricted, they will get thin. If thin blood vessels, means pressure inside that increases, pressure increases means BP increases, simple. Here what happens, they get dilated due to the not conversion of the 1 into 2, they get dilated, decrease in the BP, simple mechanism of action. Then ACE inhibitors decrease angiotensin 2 and increase the bradykinin levels, means decrease in the heart rate. Bradykinin means a decrease in the heart rate, pulse rate get decreases. Okay, then ACE inhibitors also decrease the secretion of the aldosterone, then resulting in the decreased sodium and water retention. Clear? Yes. Next one is ACE inhibitors. See the simple mechanism, this one. If you are not familiar with this, you can write this one. Angiotensin 1, see here, angiotensin 1, they cannot get converted to the 2. Why? Because means, because of this ACE inhibitors. Okay, inactive, then bradykinin component. Simple. If one cannot get formed to 2, then there is a no construction, no increase in the BP, just the fall in BP. Next one is the pharmacokinetics of captopril. Captopril they get rapidly absorbed and has the bioavailability of the 75% orally. Then peak concentration in plasma means 2 hours after the half-life period is 2 hours of that drug. Then clinical use, treatment of hypertension, treatment of heart failure, secondary prevention, after myocardial infarction, then diabetic neuropathy, and then insulin dependent diabetes mellitus, we are giving this one. Then adverse effect, dizziness, loss of taste, dry cough, headache, hyperkalemia, then teratogenicity, acute renal failure, leukopenia. These are some of the contraindications, side effects. Contraindications: hypersensitive, stenosis, renal impairment, pregnancy. In this we cannot give this captopril or ACE inhibitors. If they ask the pharmacology of the ACE inhibitors, means same you can write, same, no problem, same. Next one is a pharmacology of the carbimazole. This carbimazole, it is One more type of the anti-thyroid drug. Okay, what you studied, no, propyl uracil, propyl uracil, not getting, propyl thiouracil, sorry, propyl thiouracil, it is the anti-thyroid, the same one. This is the carbimazole, it is also one of the anti-thyroid drug. Now let's discuss what is this carbimazole. Here, here carbimazole, the same pharmacology how you wrote for the that propyl thiouracil, no, the same pharmacology. See this one. Okay, propyl thiouracil, what you wrote, no, same if you wrote for this also, no problem, it's correct. Now see what does it says. You know that anti-thyroid drugs, these are the drugs which are used to lower the functional capacity of the hyperactive thyroid gland. Means if the excess amount of thyroid gland gets secreted, to lower this excess amount we are giving anti-thyroid. One of the common example is carbimazole or this propyl thiouracil. Same mechanism of action, same pharmacokinetics also same. Then pharmacology of the diclofenac.